Yes, let's get started. So thank you very much, everyone, and welcome to Moving Ahead, Exploring New York Forthcoming 1115 Waiver. My name is Patrick Pilch. Can we turn to the next slide? So with us today is Brett Friedman. Brett is a partner at Ropes and Gray. He's the former New York State Medicaid director. Alan Miller, who's principal and CEO of Cope Health Solutions, and myself. I'm going to moderate the first part of the webinar today, and I'll rejoin at the end when we get into some of the Q&A. Let's go to the next slide before we move ahead. Thank you. So some housekeeping. So I expect there's going to be a lot of questions. We already received some questions before this webinar. Please enter your questions to the Q&A feature in Teams. The screenshot is below, and we will answer those questions at the end as best we can, given the time allotment. You also may email questions directly to info@copehealthsolutions.com. After the webinar, the attendees for this webinar will receive a PDF copy of the presentation and a link to the recording and a written Q&A. And after the presentation, Cope Health Solutions will send out a brief survey, and we'd really greatly appreciate your sharing any comments or feedback. So let's talk about the agenda, and I'll hand it off after that. So we're going to discuss the introduction to the forthcoming New York Health Equity Reform 1115 waiver and those aligned CMS CMMI programs, specifically around, as we get into the second part of the agenda, around MCP, Medicare Primary, and the AHEAD model. And then we're going to focus on some consistent themes and components from CMS and from New York State with respect to financial quality reporting, health equity, et cetera. I'm going to turn to some lessons learned from CalAIM, and we're rounding around to what we can do next, how we can plan for this, and then open for Q&A. So with that, I'm going to hand the microphone to Brett Friedman to discuss the introduction to the waiver.
Great. Thank you, Patrick. So we wanted to, before we get into the brass tacks of the components of the waiver itself and how it's evolved really over the last almost 2 years since the concept of the waiver was first introduced to stakeholders, it's important to orient the Medicaid 1115 waiver in the context of larger federal transformation goals. Because one point of education is the 1115 waiver is inherently a Medicaid program. Given the focus on dual eligibles, right, those who are eligible for both Medicare and Medicaid, as well as overall CMS evaluation capacity and CMS policy setting, what CMS will approve for an 1115 waiver needs to be in context of what CMS wants to do generally for the Medicaid program across the country. And in fact, we've seen over the last year to 2 years, a lot of Medicaid waivers that have been approved that include components that we expect to find in New York's Medicaid waiver. Not just CalAIM, which we'll talk about later, but waivers that have been approved in Oregon, in Massachusetts, and elsewhere. And so all of that comes in context. And the first point around context is, what is the role of value-based payment in the context of the waiver? There have been stated federal policy objectives that CMS wants the majority of Medicaid beneficiaries into some form of accountable or value-based payment by 2030. And in fact, dating back to 2014, when New York's prior massive 1115 waiver program, DSRIP, which many of you on the call probably know well, whether you're fond of it, I think is an experience that you may have had during DSRIP. But the core purpose of DSRIP, in addition to making targeted population health investments, was to move massive parts of New York State's Medicaid delivery system into value-based payment, first upside only, and then upside downside, or level 1, level 2, level 3, if you want to use the parlance of the New York State value-based payment roadmap. And so the first question to ask yourself in assessing New York's 1115 waiver in connection with other CMMI and CMS programs is, what is the role of value-based payment? And there is a substantial role, which we'll discuss in just a slide. The second large and big ticket goal is, what is the role of primary care? And just to relate personal experience, when we were designing and thinking about the concepts of the 1115 waiver, there wasn't as much of a focus on primary care as there had been in prior waivers. It was potentially a sense of the fact that there were already substantial primary care and care coordination programs occurring in New York Medicaid. And so did the waiver have to invest more in primary care? And as you'll see in the slide, the answer is yes, right? Primary care is the lifeblood of the Medicaid program in so many ways, and that a waiver, 1115 waiver as a source of new federal funds, needs to do a lot to support primary care healthcare providers in doing the work and the role that they play in care coordination and ensuring that patients avoid expensive care environments or are managing their chronic conditions effectively so their spend doesn't increase. And that was put in context of New York's own experience, which is, even from my last budget as Medicaid director in 2022, we made massive increases in primary care spending because New York had trailed from a cost of services perspective in ensuring that primary care rates kept apace. In addition, and this was an outgrowth of the district program, we had the patient-centered medical home program, or PCMH, which provided a per member per month add-on to primary care services to do that type of care coordination work and to ensure that programs, whether it was PCMH itself or similar programs to PCMH, were there to appropriately incentivize primary care providers to do that core care coordination function that's really expected of primary care providers in a well-functioning healthcare delivery system. So in addition to creating incentives, we also wanted to think about, and CMS wanted to think about, new investments in primary care for things that go above and beyond the direct delivery of services and care coordination, especially as we bring in new components of Medicaid, of the Medicaid program, namely this concept, which we'll talk about a little bit more, of health-related social needs, right? This is paying for services that are not traditional Medicaid benefits like food, transportation, and housing that have the ability to impact and improve the social determinants of health. And so there's a recognition from CMS in the context of the waiver that additional investments are needed in primary care as an entry point to accessing health-related social needs. And then the third is, where does the Medicaid program fit in to the larger insurance landscape or the payer landscape? And there's been a huge focus, and the reason why we called this webinar Moving Ahead is because the AHEAD model is really such an innovative CMMI initiative, which we think speaks to CMS's larger vision around the concept of multi-payer alignment, which is that if you keep segmenting Medicare different from Medicaid, different than commercial, you're going to have inherent there's going to be inherently disjointed aspect of the delivery system. Healthcare providers should just deliver good healthcare, and whether that delivery of healthcare can be as payer agnostic as possible, so that the care decisions you make are the ones that are best for the patient, regardless of the payment source, is really something that CMS is looking to do. And the early model has been what people call the Maryland model, right? The Maryland all-payer demonstration, which is payer agnostic, and we've seen similar models in Pennsylvania and Louisiana and elsewhere in the country, largely in the rural landscape. But whether from a primary care perspective, you can take and align payer strategies for primary care across payer sources, so it's less focused on payer type and more focused on the patient, is a good thing. And the last, and I made reference to this in the primary care section, is how do we integrate health-related social needs, right? Paying for things like food, housing, transportation, enhanced care management. And Alan will talk more about CalAIM and what CalAIM provided, but there's an emphasis on integrating these health-related social needs into the overall care model. And to do that, you need to screen individuals for eligibility for these enhanced services based on their need. You need to be able to collect data on who's accessing those services so that you can not just understand who's receiving them, but understand the quality and outcome impact based on different demographic characteristics such as race, ethnicity, disability, age, and to be able to risk stratify or stratify quality data measurement sets to understand where these interventions impact care delivery based on these different demographic population types. And then to measure ROI, whether if you're investing in food, housing, and transportation, whether they're actually impacting healthcare spend at the end of the day. And then once you've done all that, to ensure that you can preserve those strategies that really work to improve overall health outcomes and health spending. And so these three big ticket buckets, which we've seen not just in waiver initiatives across different states, but also in CMMI federal initiatives, are really the context around by which New York is seeking approval of its current 1115 waiver. And so with that context, let's change slides and move into where the waiver is and what we expect to be in it. I will not bury the lead, and I'll say I do not know when the waiver is getting approved. I think we all hope very, very soon. As I mentioned earlier, New York has been at this, and I've personally been at it since 2021, designing a concept that CMS can approve that aligns with the context that we just discussed in terms of the national landscape. And based on reports from DOH and others, and where we see other waivers existing in their approval processes, I think the expectation is any day now, or we sort of hope any day now, whether that's before the end of the year or early next. But I think undertaking an appropriate strategic planning process with the expectation that the waiver is going to be approved and approved soon is a very good thing for providers to be considering now, which is what makes this webinar important as part of that education process. But just as background, New York submitted the waiver for CMS approval back in September of 22, which kicked off the federal review process. They had requested $13.52 billion of new federal match authority to make investments in new aspects of the healthcare delivery system to see if these new interventions and payment models would be effective at improving care and lowering costs. That's what waivers do. And in any education process I've given for a waiver, I've said, these are called research and demonstration waivers for a reason. They are research projects, right? There's like a capstone evaluation because you are inherently investing in new things to see whether you're getting the outcomes you want. And those outcomes could be better quality, it could be lower cost, it could be improved patient experience. But at the end of the day, you're testing new interventions to see whether it's improving the overall fabric of the Medicaid program. And that's the beauty of the breadth and depth of what 1115 waivers allow you to do. So New York said when it submitted its waiver following a longstanding and publicly oriented stakeholder development process that we wanted to invest $13.52 billion of new federal funding in interventions. And the interventions were spread across 5 major components. And this is our own organization of how we're segregating the waiver application and concept paper into something manageable. But whether you call it 3 buckets or 5 buckets or 8 buckets, I think this is a good way to conceptualize what the waiver is trying to invest in. The first component is the need for additional facility support. This is a consideration really in any waiver, right? When you're transforming the delivery system to do new things, you have to help the large scale facilities. I mean, we say hospitals, but it's not just hospitals alone, readying themselves for that transformation and asking them to do the new things that a waiver requires. And so there would be a substantial component of the waiver that would go towards providing typically a quality pool-based structure for hospitals that elect to participate in key components of the waiver. And importantly, and we saw this in district with the value access quality pool, the VAP program, that as a quality program, hospitals can access this funding without impacting their dish caps. And so the waiver being an authority for funding for distressed facilities and safety net facilities is a key component of any waiver, especially when it's asking a hospital system or another type of facility to make large scale change. And so we will expect, and I would expect there to be, a component of hospital subsidization funding in connection with the waiver approval. And then the question is, how does that funding align with other sources of safety net hospital funding that the state's provided both through DSRIP and after DSRIP, through programs like directed payment, the Indigent Care Pool, and DAP, which is an operational support program using state-only funds. The next component of the waiver, which I really think is the most critical and innovative component of what New York is seeking, involves the investment in social care. And New York has proposed to do this through the formation of regional social care networks, none of which is meta, but that there would be these regional social care networks which would provide infrastructure and be a conduit for funding to community-based organizations that deliver social care services to individuals in the Medicaid program who qualify. And the waiver funding for social care would be in two components. One would be an infrastructure funding bucket to help build these network entities and provide some of the technological and physical infrastructure necessary to do that work. Think of closed-loop referral systems or network tracking tools. CBO fee schedule, things that are necessary to pay for new service types, and then actually provide waiver funding to CBOs that deliver food, transportation, housing, enhanced care management, and other services that are typically not paid for by Medicaid. And it's unclear through the current waiver application how exactly the funds would flow, right? And I think this is something DOH is working on, whether the funds would flow through the SCNs or whether the funds would flow with the SCNs providing more of a facilitator function, and how existing IPAs, independent practice associations, that have already begun coordinating the work of CBOs in different regions, and some of which were named in the concept paper and the waiver itself, could feed into the social care network structure and ensure that CBOs and that there's timely payment for the services pursuant to the fee schedules developed for these services. This, just as a former Medicaid director, enormous operational lift, right? You're really delivering a whole new service delivery vehicle, and how that aligns and how those with existing Medicaid programs, how you can track outcomes, how you can ensure that providers are receiving the right payment for the services, all things that will have to be developed if and when the waiver is approved. The third component is primary care. And so, ensuring to the federal initiatives I discussed earlier that you're making the appropriate investments in primary care providers who treat significant portions of Medicaid patients to do the things that are now required to bring HRSN into the delivery system. And, I was saying this to Alan and Patrick before, right? There's two ways to think about HRSN services. The first is as a Medicaid benefit that individuals are receiving that would be authorized by the managed care organization that's serving the member generally. And you have a health screening, you have a care plan, you have a service authorization, and then you have service delivery. And that kind of treats the HRSN as like under this benefit concept. The other way to think about HRSN is really as a prescription, right? Which is, a patient comes into the primary care office, they have food insecurity. There's actually like an ICD-10 code that corresponds, or a Z code that corresponds to food insecurity. And then the primary care physician can write a prescription for a food box, similar to the way that they write a prescription for a prescription drug. And I think the waiver and the waiver design can accommodate both concepts of HRSN, but the latter design really imposes the obligation on the provider to do the diagnostic assessment, code appropriately, connect to the SCN, refer, and make sure that the patient received the social care service that member needs based on their eligibility class and their screening tool. And so there's a huge role of primary care in that concept that needs to be invested in and built out. And part of the waiver investment, the 13.52, however it ultimately gets approved, would go into building that infrastructure, similar to PCMH, similar to other investments in primary care that New York has already made. Then we get to the smaller elements, which is workforce funding. But there was a recognition through COVID-19 and otherwise, and we've seen it, and it's still persisting, that the healthcare workforce is strained. And so because 1115 waivers are inherently research and demonstration programs, can New York do things that are truly innovative and improving and strengthening the New York healthcare workforce? What those programs are, the waiver application's fairly light on them, but looking at other states, like the training loan forgiveness model in Massachusetts, the historical work that the WIOs, the Workforce Investment Organizations, have done under DISRIP to build the long-term care workforce and training, are all things that could be potentially funded under the waiver. And finally, we have the concept of the HERO, which is the Health Equity Regional Organization. And it's a bad acronym. I probably take partial responsibility for creating it, which is that there's a sense that there needs to be an entity that is trusted and data-driven, that provides the ability for regions to define where their social care investments are needed. New York is such a massive and disparate state, right? The needs of what's in the North Country are so different than the needs in the Bronx, that weaving together different data sets, whether it's data sets from homeless services, the foster care system, the criminal justice system, so that there can be an appropriate data ingestion and analysis, so that the investments, whether by virtue of managed care, the SCNs or otherwise, can be targeted to populations in greatest need and who are likely to benefit from the services to the greatest extent to generate that ROI that we talked about earlier, is critically important. And there's, not to surprise anyone, there's a lot of distrust between different components of state government, or between state and local government. And so can the HERO be this trusted data-driven entity that helps think about where the social care investments are most needed? In addition, because waivers are research and evaluation programs, and the HERO has a substantial data evaluation capacity, the HERO can help with evaluation design, data aggregation, and the assessment of regional need. And so there is a role for the HERO. It's probably, and we saw some questions earlier, right? How has the waiver evolved from the concept paper and application to now? I think the role of the HERO has tightened to be less of a gatekeeper to funding eligibility and more of a evaluator and data aggregator, which is a critical component of any waiver. Next slide, and then I will cede the floor soon. So we talked about the federal themes, and we talked about the waiver design in particular. And so you have to think about it, in the context of other federal initiatives that are coming together and that have been in place for, in some cases, 10 plus years, because, and I think CMS is learning from its past mistakes, where an 1115 waiver can't operate in isolation from other longstanding CMMI and CMS demonstration programs, largely authorized through the funding authority under the ACA. And there are four in particular that we wanted to highlight that are substantially related to some of the concepts furthered by the New York State application and discussions around the 1115 waiver. And the first is one where the application deadline just lapsed on 12/14, but it's making care primary. Patrick referenced it earlier. This is a physician investment type waiver CMMI program where it's targeted to individual primary care practices that are new to value-based payment, right? So it's providing that funding investment in different tracks, and we won't get too deep into MCP, so that primary care practices can start shifting their practice patterns to move towards value-based payment and connect with the need for primary care to be a delivery conduit for health-related social needs. It's targeted to Medicare beneficiaries. It has a very low attribution threshold, and so it allows many smaller individual primary care practices and fairly qualified health centers to qualify. And it's a 10.5-year demonstration, which is enormously long for a CMMI demonstration, not as long as AHEAD, which we'll talk about in a bit, but it reflects the fact that it's going to take primary care practices a good long while to get to the place where they can effectively participate in value-based care and other elements of care delivery reform that are expected of primary care. It is limited to 8 states, including upstate New York, which to me suggests that CMS is trying to align MCP investments in some of those primary care investments that are in the New York State 1115 waiver. Then we move into the ACO programs, and these programs have been around for the Medicare Shared Savings Program really since the inception of ACOs and CMMI generally, to ACO Reach, which has been only in the last couple of years. But these are, essentially shared savings, shared loss models, and they allow practitioners, providers who participate through these ACO models to share in risk if they lower costs below a defined benchmark. We could do a whole webinar on AHEAD or MSSP, but these have traditionally been on only the Medicare fee-for-service population. They have encouraged physicians and other practices and providers to move into these shared risk models. And they renew kind of annually, but AHEAD is now closed. You can still participate through an existing AHEAD ACO, but they have, as opposed to the low market impact that MCP has because of it's a newer entrant, it's a smaller physician practice group. The potential for market impact for ACOs have been pretty substantial. We classify them as moderate to really contrast them with AHEAD, which I think has a huge impact. But these have really moved physician practices and other providers into thinking critically and really being able to generate shared savings for reinvestment in value-based care models dating back 10 plus years. And then we have AHEAD, and this is the new kid on the block, the most recently announced CMMI initiative, and it's very transformational, extraordinarily so. And again, we could do a whole webinar just on AHEAD, but it's a voluntary model. It's limited to 8 states, including downstate New York. Again, the fact that New York has been essentially pre-selected for AHEAD by CMMI suggests that CMS is likely trying to align some of the things in the 1115 waiver with what they're doing on the federal side across the country. And we in New York have been moving over the last 5 or 6 years to really contemplating global payment demonstrations similar to Maryland in certain parts of the state, whether it's the North Country or the Bronx. And so the fact that AHEAD has come as a federal or a national payment model that looks to align all payers, Medicare, Medicaid, and commercial, into a single global budget, which is trended annually and which pays for all healthcare services in a region, has an enormous transformational impact, right? This is saying to providers, hospitals, and primary care practices in a region that we're going to fix your reimbursement. We're going to move away from traditional attribution models into something that's more regionally attributed. And we're going to hold you to cost growth and trend as opposed to an annually recalculated shared savings benchmark, which is how the ACO programs have run. And if this is effective, it's really an enormous opportunity for these providers in the delivery system to transform effectively, because it's stabilizing their revenue model. It's saying, what you're going to get paid. And so you can start thinking about how to reconfigure not just your own services within the health system, but also your geographic relationships to ensure that the individual is receiving care in the highest quality and lowest cost environment. And by then right-sizing the trend from a year-to-year basis, both the federal government and states, which are responsible for the trend, and the providers can both benefit against that change in the payment model. I mean, this is like, if I can emphasize nothing else, enormous big picture thinking on the part of CMS to try and really change the payment paradigm in a region. And the reason why we score the market impact so highly is because if these payment models are implemented and they're effective, it really just flips the payment paradigm on its head by changing the way that, really it's sort of killing the fee-for-service volume-driven model into something that is globally set and trended so that performance can be predictable and well managed. So yeah, that's the context. Next slide, please. And just some things to think about, because we referenced on the prior slide, but thinking about the impact of MCP and AHEAD in New York State, what CMS has said is AHEAD is a downstate model. Only hospitals in that little blue circled area are what are eligible for AHEAD, right? It's not a statewide model. And because AHEAD is downstate, MCP is upstate. And so CMS is already contemplating the regional variation and needs that New York has as a large and diverse state in terms of their healthcare delivery systems. And so for providers, and this makes our jobs as lawyers and consultants both harder and more rewarding, is that we can't, your advice is going to, and your considerations are going to have to be very specific to your geography and to your needs, right? What may work for a hospital system downstate is going to be very different than what works for a hospital system or an FQHC or a primary care provider in Buffalo, both in terms of the interlocking impact of the waiver with CMMI programs with what commercial payers may be doing. So like everything else in the healthcare, the trend has been towards complexity, but with also a tremendous amount of opportunity. And so with that, I will hand it over to Alan to really align and think about what the themes and components are of these various opportunities as providers have to think about the impact on their own bottom lines.
Thank you so much. I really appreciate it. And you guys can hear me okay. So, and Brett, I think Brett did obviously fantastic job really laying a foundation and talking about some of the key areas. So I'll just add a little bit of color to some alignment here. Government policy varies, right, and how well aligned it is. But if you can see some themes in what the feds and the states have been doing, we're very fortunate to get to work in multiple states, and particularly a lot in California and New York. And so really understanding how some of these things are consistent. And so, some of you are maybe in the AHEAD, or pardon me, maybe in the ACRE model. Some of you may be in Medicare shared savings models. And you may be asking yourselves, well, how is that going to work with all this, right? Some of you may have been already looking at, because the Making Care Primary deadline just passed, back when the ACO REACH deadline to stop, people were thinking about, should I get out of ACO REACH, move to Making Care Primary? There's an MSSP deadline further down the road that we'll talk about. So there's a lot of questions about what program should I be in, and how do all these programs interrelate? And there are a few themes that I wanted to go over here, and then some thoughts for folks. So one of the themes that is very consistent nationally is this whole idea that we need to make social determinants of health a part of the clinical and financial. And it's very important to consider that it's not a new idea. So, this whole idea that food security, or, food as a prescription can help people. There are Medicare Advantage plans, of course, nationally doing that already today, right? This is it's not a new idea. Folks who've been taking risks have been putting air conditioners into people's apartments or houses during hot episodes to make sure people don't go to the ER for dehydration. So one thing about social determinants is to remind all of us that there's a long-term evidence base for this. There's a lot of experience in folks taking risk to help people ensure that they're going to be safe at home, ensure that they have food, ensure that they have transportation. Sometimes the regulations have gotten in the way. What we're seeing now is this consistent trend where CMS and the states are saying, you know what, we need to make it easier for folks to be able to invest in and pay for these services, and it needs to be aligned with the managed care model. They also are looking for more evidence, right? What works? What's the return on investment for these kinds of things? So the real consistent areas we tend to see are housing related, including things like recuperative care, PACE type day rehab type programs or day habitation type programs. A lot of care management, whether it's care transitions, even from SNF to home, whether it's enhanced care management type programs, and certainly again, meals and transportation. There's also sobering and substance abuse in California, for instance, as a focus there on some of these areas. Again, there's some variation, but the consistent issues to really keep in mind is number one, you cannot improve what you don't measure. So the CMS and the states are working on a consistent way to be gathering data on people's social determinant needs, right? So getting that evaluation done, that assessment done, whether it's during an annual wellness visit, whether it's through your care management program, but being able to pull in that information, understand it, and then again, being able to have a process, as Brett talked about, to pay for it. And either having a physician prescribe it, how is it ordered for someone and how is it paid for? And I think what's important for folks to consider in California, we talk a lot about how, these programs will come out and they'll be paid for a while, and then they become an unfunded mandate, or another way to look at it is an opportunity to be integrated into your care and financial model. So folks want to be thinking about how does this fit in my long-term sustainable financial model? It goes back to what's the ROI? How are these things helping my members to have less hospitalization, improve their medication adherence, right? Improve their quality and their care gap closure. One of the things that's very important in California that they're learning, we'll talk a bit more about this, is that enhanced care management and the contracting for these social support services, it's very important to think of it as also a way to improve quality, right? There's a direct correlation to both premium, but also people's health. Primary care access is a really big one. It's so important. And again, MSSP may not incentivize primary care access, but of course, MSSP is very friendly to primary care groups to join. There's so many different levels of risk you can choose. The other programs all have actual and enhanced payments and investments to really grow primary care. I was just looking recently, AAMC recently projected that we have a 37,000 to 100,000 shortage of primary care providers over the next decade. So part of the consistency here is that there's just a huge need to improve primary care access. We've got a real problem in this country, as opposed to particularly in New York, hospital beds. New York has 2.52 beds per 1,000. It fits in about the middle nationally, whereas California has 1.84 hospital beds per 1,000. There's a huge differential in terms of hospitalization rates in California versus New York. Part of it is that longer term managed care penetration and business model. But important to consider that where everyone is trying to go from evidence base is how do we expand primary care and leverage that to reduce very expensive services utilization. There's really, at the end of the day, no other way to reduce total cost of care than reducing acute care and very expensive, especially ancillary care and pharmacy, to the extent that, of course, you're also improving utilization and adherence to drugs that help folks. Lots of stuff you can do around the edges, but those are the key areas. The other thing is that, again, we talked about the fact that if you don't measure it, you can't improve it. So all of these programs have very specific targeted performance benchmarks, which is great for folks who also have value-based care agreements with payers. Now, great and not great. One of the challenges we have in healthcare is that everybody wants their own quality program. And we're not going to see a magical transformation where all of the quality metrics and programs become deeply aligned. But a lot of the activities that you need to do to improve performance on these various quality programs are pretty consistent across the board. Again, and a lot of the time it's having folks think about the big picture: access, right? Satisfaction with care. Are we closing care gaps? Are we closing some of the social determinant gaps that prevent people from getting care and from taking care of themselves? And then, of course, they all have risk sharing methodologies. Some of them start with capitation, some of them move toward capitation, like AHEAD for primary care. There are some subtle variations and things to keep in mind. AHEAD, for instance, if you're not an FQHC, it's only available to you if you're aligned with a hospital that is actually taking global budget under AHEAD, for instance. So there are some key things to keep in mind with some of these in terms of who's eligible. But again, any of these programs are designed to help primary care better manage populations and really align networks. Again, we talked about quality scores a little bit as well. And then finally, health equity. So this whole idea of improving care across the board, right, irrespective of vulnerable population status, ethnic background, and linguistic barriers. There are, having been in healthcare a long time and starting in California and then working nationally, right, there are so many barriers to care, many of which are linguistic, income driven, racial bias driven, so many different challenges. And so again, with these, what we ask folks to think about is, yes, you have to follow the bureaucratic rules, but why are you following it? What are you trying to do, right? At the end of the day, if you're trying to make the community healthier, are you looking at things like having your providers reflect the community linguistically, culturally, ethnically? Do people feel welcome accessing care in your environments? Are they enjoying the experience, even if they're quote unquote, low income folks? Do they want to come to care? Do they feel valued? And certainly, are we helping them again? As I talk about when I started my career volunteering at a free clinic to take care of folks medically, the medical care was not always the most important thing, right? If you have a mom who comes in with a 5-year-old with a little fracture in their forearm that's going to heal in 6 weeks, but mom doesn't have access to food for the kids, right? She can't get a job because she's undocumented and she's in an abusive relationship. You have to ask yourself, where's she going to focus her attention, right? So are we helping her on some of her core areas that she's really struggling with? So next slide. So this is a timeline slide. For me, it's helpful at least to kind of put all these things together and understand from a strategic perspective as an organization, how do I think about my organization's strategy? And we always tell people, align the government programs to your strategy, not necessarily your strategy to the government programs. They're all going to have, again, as we've talked about, very similar themes and requirements. There will be some very specific bureaucratic dotting of I's and crossing of T's that you will absolutely have to understand. But what you really want to focus on is your strategy to be sustainable and serve your community. And then how do you pull in the right government programs to help you succeed with that? All right. And so understanding the timelines certainly helps you. So a couple of things to really keep in mind here. I talked about the fact that AHEAD is not available for non-FQHCs where the hospital is not taking AHEAD global budget. So you have to certainly pay attention to that if you're not an FQ and you're interested in the AHEAD program. Making Care Primary, the deadline has passed. So at this point, that's not an open program for the coming year. ACO REACH also does not currently have an application available. The assumption is that, as has happened over time from Medicare Direct Contracting, where there's Pioneer, Medicare Direct Contracting, ACO REACH, there will likely be another model down the road when the ACO REACH timeline is over. And Medicare Shared Savings, the expectation is that that will continue to have an annual application process, most likely. So that's one that folks can always be thinking about whether or not they want to explore. And some of these you can move in and out of. Again, it's just important to understand. The other thing to keep in mind is that for Making Care Primary and AHEAD in particular, but it also works for ACO REACH and MSSP, those are Medicare, of course, right? So then aligning your New York waiver, your state Medicaid strategy for value-based payment, it's important to of course have a consistent strategy across your lines of business. And what the feds and state are trying to do is align some of that so that you can be in value-based payment across the board and really transforming care across the board. Next slide. So I wanted to talk a little bit about what we've learned from CalAIM. So our firm was actually born in Los Angeles. We're spending a lot of time in California right now with health systems and plans and FQHCs and others working on this CalAIM program. And, first of all, like any program, it's partially what you make of it, right? I mean, these programs never launch cleanly. There are always all kinds of challenges. CalAIM got up to a very slow start in California, and there are still a lot of challenges. And so some of the things for the state of New York and the plans and the providers to learn from, one of the areas that is incredibly complicated for people is eligibility for the enhanced care management model. So in California, there's an enhanced care management model that is not unlike Health Home. And there are a couple of issues. One is that other than FQHCs, which of course are also primary care homes, there hasn't necessarily been really good alignment between IPAs and primary care groups that aren't FQHCs to integrate the enhanced care model into their care management model so that you have a very consistent care plan. Instead, there are different CBOs providing different flavors, kind of crossing the community. So there's a lot of disruption and confusion about who's my patient and who's my provider and who's the CCM group. The other issue is around eligibility. A lot of challenges. I was talking to one of our clients, it's a very large FQHC in California, and they were telling me that they're handicapping themselves 47% on all their enhanced care management revenue because they actually got a big clawback last month due to eligibility confusion. So very important going in as the waiver starts, and we always tell everybody, right? So important to understand the rules of the road and work with your payers to understand, hey, let's talk about how to structure this agreement in a way that we have really good definitions on data that's going to flow, on eligibility rosters. One of the things we notice generally when we work with providers is that there's this tendency, which is not abnormal, it's just a tendency to take what the health plans give us in terms of contracts and then maybe kind of respond, right? And focus on things like rate. What's really important for providers to think about, whether you're a CBO that's going to provide some of these services, behavioral health, primary care, IPAs, which we urge to really think about this because they play such a critical role, health systems, is that you want to think about what am I going to need to be successful from the plan? And let's make sure that's in the agreement. Defining attribution, if attribution is there, are we defining eligibility? Are we defining the data I'm going to get and when I'm going to get it and how I'm going to get it, right? So that I understand not just payment, because again, payment only happens when all those other things are functional. So those are lessons learned, to be honest with you, from contracting and value-based care generally, just simply have been exacerbated in California with CalAIM, which by the way, overall appears to be a really solid program and a great opportunity for folks. Again, there's just a lot of technical challenges, right, and operations challenges, some of which are the growing pains, and some of which could be cured through really intentional contracting and design of your relationships up front, some of which are very, very data driven. So those are some of the key things to keep in mind in terms of lessons learned. Again, the other one is that IPAs or community clinical integrated networks, for instance, so folks that are organizing FQHCs and private physicians to really provide a better value care, right? Reduce total cost of care, hit the quintuple aim. Those folks have a big opportunity. And again, in California, what we found was that a lot of them were not necessarily ready to jump in and drive value through enhanced care management and community supports, right? Which are the SDOH supports for their IPA providers. And so what we urge folks, and of course there are hospital-based clinically integrated networks and there are community clinically integrated networks, right? Where you're organizing all these doctors. And so we always talk about, how are we adding value to the doctor, right? Are we giving him good data? Are we giving him good value-based payment arrangements? Are we providing a good care management model? So one thing to think about as the waiver and AHEAD come out is from a community clinically integrated network and hospital clinically integrated network perspective, what value are we providing to our physicians, other providers, and community groups with relation to data, care management, being successful in this model? So I won't spend much time on the next slide. You're all going to get the deck, by the way. Quick reminder, you're going to get a recording, you're going to get the deck. So what I'm going to do now is I'm going to pass it over to Q&A. We'll go to the Q&A slide. It's about 9 minutes left. And kick it off to Patrick. So Patrick, folks have been asking, pretty much everybody I ever talked to, all right, so what does this mean for me as a provider? What do I need to do next?
So this presentation actually haven't been working with both of you for a while. As every time I talk to you, I learn more about this. I look at I focus on what are the known facts we have. We know in Medicare by 2030 we're moving to a value-based model. That's CMS's goal. We know what the overarching reasons why the New York State Medicaid waiver has been put in place and applied for is to lower total cost of care, to improve outcomes. So in order to do that as a provider, I look at it from a standpoint of what do I need to do to prepare my organization? And part of that would be looking at your current resources. That ties into all the stuff we talked about. We talked about quality, community, the clinical network you're building on, but really assessing your current resources, both financial, human resources, your workforce, your capital structure, because you are moving towards ultimately a value-based, risk-based model. in terms of a global budget, and stress test it. Make sure that you manage the liquidity of your organization, not just during that process where you stand right now, whether you're a distressed provider or you're a healthy provider. Really understand where you stand and then how you bridge to a future state. And looking at from the standpoint of how to manage through that process in terms of cash flows, how to manage behaviorally, because it is a different model. And looking at the profitability and not just profitability, but also understanding the need for certain service lines. If there's other partners or providers in the market that can serve the community better, if you were aligned differently, those are all the considerations that we would certainly look at. And then going deeper, this is going to require a care model redesign, and Cope does that tremendously well. And also the kind of what the network build looks like, and how you can optimize it so you can be designed for this future state. Whatever the future state looks like when the waiver comes out, that's what I would do. At least take an understanding of what you have currently, manage it effectively as best you can, so that when the waiver does come out, you're in a position of saying, this is what I have, this is what, and then understand this is what I need to get to that future state. That's the approach I would take in this.
Yeah, and Patrick, I just want to add one thing, because this is, we skew in Medicaid especially towards complexity, right?
Mm-hmm.
And that's it's like you kind of hope you could like burn it down and start fresh and only do the things that are working and not do the things that aren't working. The Medicaid program, both pre-COVID, during COVID, and now, has only increased in complexity. The program has grown more, we do more, we covered more people. And so I think, Patrick, building on something you said, is my recommendation to organizations is there are new programs coming, right? Whether they're federal only or combined federal state. And so as part of that, you're going to have to invest capacity and resources into these new programs to capture new payment opportunities. What are you doing now that you're going to cut? Because it's either losing money, it's not working, it's not effective for your patient population, you have a change in mission. And you should do that anyway as part of a process of continuous improvement. But I think, this is going to be a resource drain.
Yeah.
One thing I'll also, and I saw a question just come through. Again, there's so many questions about this social care, and kind of, I think maybe call them social care networks. How does that work? We were very fortunate to be allowed to work with a group in Binghamton. They were the Care Compass Network. They were actually a PPS under the last waiver, and they wanted to transition into a more sustainable state. And then they did this themselves. We were along for the ride, able to provide some advisory and expertise and experience, but they really did a fantastic job, and they created a social IPA. But the model for that social IPA really is to support health plans and payer and risk arrangements to drive down the total cost of care and improve quality. And so what I would think about, if you're a community clinically integrated network or an IPA, or health system one, or a behavioral health IPA, or one of these groups that's looking to organize social services, right? Whatever that ends up being in the waiver. If you're on the managed care side of things, don't assume that social care supports and enhanced care management is someone else's job. Make sure your members and your doctors are getting what they need. And the question is, do you partner with someone, or do you do it yourself? And sometimes you might find it's worth doing it yourself, even if you don't get extra money for it, because again, it integrates the model and it provides better care and better outcomes, like some MA plans are already doing nationally, right? And folks have been doing in California for a long time. If you're on the side where you want to be like the folks in Binghamton, there's one in Albany as well. You want to be an organized group of CBOs that provide services. You really have to think about, what's our value proposition? Forget the state paying me. Okay, the state will give me some infrastructure. The state will pay me for a while. Eventually, this is just going to fit in the premium somewhere or some program. There's not going to be extra money. And so your question is, how am I adding value to the clinically integrated networks out there? Why do they want to buy or use my services versus doing it themselves? So I would urge people to really, again, as Patrick said, focus on your core business, what's going to be in your core business. Mm-hmm. But don't forget, if you're in the medical care business, you're also in the social care business, and you're also in the care management business. Otherwise, you're not going to succeed. So I know we have about 3 minutes left.
3 minutes left. A couple of other questions. We are seeing shortages in primary care physicians in New York City, especially in the reduction of GME programs for primary care / family medicine residency. Do you anticipate the 1115 waiver to prioritize primary care and prevent PCP shortages?
Brett, that sounds like a design. I can talk about how to help do it. That's a Brett question.
Yeah, I mean, the short answer is I hope so, and yes, that, you know, part of both the primary care component of the waiver investment, which DOH talked about during the UHF conference in July, I think will definitely go to that goal, as well as I'm really intrigued to see what ultimately gets funded through workforce initiatives. There's a concept of, you know, I mean, GME has largely been the domain of the Medicare program through GME caps and the GME program. I think that, you know, but whether we can supplement through other allied health professionals to increase and enhance supportive primary care through those programs, I think will be critical. And one of the elements about AHEAD, and Al and I discussed this, that's really not yet clear, is that if you're going to move Medicaid into a global budget, most Medicaid revenue, or not most, but a lot of Medicaid revenue is not necessarily utilization driven. It's actually driven through GME, IME, and DISH, which are supplemental payment programs that tie to things like medical education. And are those going to move into the global payment programs too? Because if they don't, then you're really leaving, you know, a lot of revenue opportunity through these programs on the table. And so there may actually be an interesting component through AHEAD that may work to enhance and support and change the way that health systems think about their GME programs.
Totally agree. And again, as I said previously, right, if you're a provider, I hate to say it, but don't wait for the feds in the state to solve your primary care program. The nice thing about advanced practitioners, so nurse practitioners and PAs, is that you can train them up and you can really change the culture of your primary care physicians to get more of those folks involved. There simply is not a physician-driven way that we can see to close the gap for the needs that are coming. And so, again, urging folks to really think about known opportunities to have a care team approach, use advanced practitioners. You know, don't get me wrong, we all want to advocate, we want the government to pay more for primary care. But we also can't wait for GME to catch up, as per Brett's point. You know, it doesn't move very quickly.
So we are at a closing point at this time. A number of questions were submitted both during the webinar, but also at previous to the webinar. We'll do our best to put them together, provide some answers, and expect that with a recording of this presentation, a PDF of the deck that was presented, as well as a survey following from Cope Health Solutions. And we really appreciate you responding to the survey. We packed a lot in an hour, and we probably could have gone 3 hours, but people have to work in their day jobs too. So appreciate your joining us today and look forward to speaking with you all soon. Thanks so much.